Good afternoon, everyone. My name is Tracy Mitchell. I'm a registered respiratory therapist and certified asthma educator at the U.S. Environmental Protection Agency in Washington, D.C. EPA is pleased to host you today for an important and exciting webinar presentation demonstrating positive asthma outcomes, collecting and analyzing data to make your case. Our esteemed and very knowledgeable presenters today are Kevin Kennedy, Program Director of the Environmental Health Program at Children's Mercy, Kansas City. Mr. Kennedy has been involved in environmental health science and healthy housing advocacy and industrial hygiene chemistry consulting for over 30 years. He teaches courses in environmental health assessment and investigations, environmental measurement and sampling, building science, and safe and healthy housing. He received his master's degree in public health from the University of Kansas Medical School. Kevin is a certified indoor environmental consultant and previously worked as an environmental analytical chemist and research scientist. Next, you'll hear from Dr. Ben Francisco, Professor of Pulmonary Medicine and Allergy in the Department of Child Health at the University of Missouri School of Medicine. He is founder and director of Asthma Ready Communities, a statewide initiative for improving asthma care and outcomes. He is the past president of the Association of Asthma Educators and author of Interactive Multimedia Program for Asthma Control and Tracking, or Impact Asthma Kids. Dr. Francisco is a practicing pediatric nurse practitioner, providing specialty asthma care to infants, children, and young adults. He has served as a contractor for the CDC-funded Missouri Asthma Prevention and Control Program for 15 years. EPA is proud and eager to support and shine a spotlight on these partners so that they can share their information and stories in order to teach us all about how data can be used to improve asthma care and how to move whole systems to bring the best care to the people who need it most, particularly children. Thank you for joining us for this important discussion today. As a reminder, after today's presentation, our question and answer session will take place on the discussion forum of AsthmaCommunityNetwork.org. This is a great opportunity for you to interact with today's presenters. The directions to access the discussion forum are on your screen right now. You do have to be a member of Asthma Community Network to take part in the discussion forum, so if you're not a member, please take a moment to join. It's quick and easy, and you'll be able to interact with our presenters after the presentation. Also, this webinar and the question and answers will be archived on AsthmaCommunityNetwork.org, so you'll definitely want to be a member so you'll have access to this information in the future. So now that we've introduced our presenters, I'd like you to introduce yourselves by telling us what type of organization you represent. So I'd like to open the poll, and please choose the option that best describes your organization. Great. So we have a wide variety of disciplines represented, a diverse audience, and I'm excited that we can learn and share from each other. Our next polling question, just to get an idea of how you're currently using data in your program, please choose the answer that best reflects your current data use. Are you collecting basic data but not really demonstrating results? Are you using data to show positive outcomes and return on investment? Are you targeting high-risk patients through the use of data? Are you translating complex data to improve asthma care? Great. So about a third of you are just collecting basic data at this point. I think we have a lot of information for you today to help you with turning that into demonstrating results. There'll be some information on all of these topics, ROI and at-risk populations. You've come to the right place. So learning objectives, as I said, we're going to learn about the basic framework for data, what you'll need to show positive outcomes for your program. You're going to learn how to use data to help your program provide in-home services, assessments, and education. You'll hear how complex data can be translated to help clinicians improve their care for asthma patients. And you're going to hear best practices for reviewing data to identify high-risk individuals. I just want to take a moment to talk about EPA's role in asthma care. So we all know that the environment plays a critical role in asthma. And at EPA, science informs policy and forms the foundation of our program approaches. Science tells us that along with medical management, there's strong evidence and supporting national guidelines that recognize the role of environmental triggers and their remediation as an important part of comprehensive care. We know that eliminating common indoor triggers like tobacco smoke, pet dander, molds, cockroaches, and dust mites results in decreased symptoms and asthma episodes and improved outcomes for people with asthma. We also know the importance of home visits as a critical component of asthma care, particularly for at-risk populations. Home visits provide one-on-one time to educate families, assess their environment, and help them remediate triggers. As technical experts on the built environment and health, EPA has led the federal non-regulatory strategies that enable communities to deliver and sustain in-home environmental asthma care aimed at ensuring access. So how does EPA's program support programs at the state and local level? So these 5 cogs represent the five basic program elements of EPA's program. First, we host learning spaces. We've talked about AsthmaCommunityNetwork.org, which connects over 1,000 programs across the country. We provide technical assistance through cooperative partners and cooperative agreements. We recognize and leverage excellence through our competitive National Environmental Leadership Award in asthma management. EPA is working to advance policy on the national level through collaboration with Asthma Disparities Working Group federal partners and locally through regional asthma summits. And finally, we synthesize and spread the learning in a variety of ways, and one example is today's webinar. So here we are today to talk about one of the central pieces of asthma programs, data collection and analysis. We hear from many community-based programs that this is an issue of importance. Some programs are much further along in developing sophisticated data practices, and others are just starting out. I think we saw that reflected in the poll, the second question we asked today. It's important to collect the right information. I think we can all agree on that. But how will this information be used? Who are the decision makers we need to target, and what data will be most compelling to them? For example, health plans may want to hear about cost savings, but Medicaid may also want to hear about the high utilizers and the services provided. Using data is necessary to build the evidence base and to make your case, and you'll hear a lot about this from today's presenters. And also on Asthma Community Network, there's information about building the evidence base. Using data to develop your value proposition is also important. A value proposition is an analysis and quantified review of the benefits, costs, and value that an organization can deliver to customers or funders and other stakeholders. It's a succinct statement that clearly describes the tangible results a customer gets from your program. It's a way to get support for your program and to draw interest and share success. And we have more information on that in this webinar and on Asthma Community Network. We also know it's important to move from collecting data to showing impact. Given our shared goal of advocating for sustainable financing, what data supports that goal? That's what our speakers are going to talk about today, using examples from their work in Missouri and with the groups they worked with around the country. So without further delay, I'd like to turn it over to Kevin Kennedy for our first presentation.
All right. Well, thank you very much. Thank you for inviting me. It's an honor to be here. It's an honor to participate with Asthma Community Networks. I've been involved actively for a long time. I'm particularly honored to be part of the webinar with Dr. Francisco. I've worked with him for many years and consider him a true expert in the data analysis, and really a great opportunity to hear what he has to say. I do not consider myself an expert per se related to data, but I am part of a team here at Children's Mercy Kansas City that has used data in evaluating our program and to measure our successes and our challenges along the way. So I'll provide one perspective, and then we'll hear another one from Dr. Francisco. So really the goal of our program, we've been going to homes since 1995. I've been fortunate to be here at Children's Mercy Kansas City for about 20 years, where we have built a home visit program related to a variety of health conditions. But we started out focused on asthma and developing a practice for offering effective assessments and effective interventions for children with such a significant environmental disease. But you have to understand the success of your program or where your challenges are, and being able to use data helps you understand what kind of successes there are, what kind of challenges there are, and how to make your program better. And really, the point is how we help Jeremy, how we help kids with asthma feel better, be able to do the things they want to do with their lives. The ability is there, the disease management strategies are there, the medicines exist. It's just effective teaching of families both about how to manage the disease and how to manage their home to make their lives easy to do, easy to participate in. There's lots of great information, fortunately, in this field, so much so that I was wonderfully surprised to see this report from the National Governors Association, this white paper from our governors for our states, pointing out that health investments related to asthma, to addressing asthma in children, is well worth the investment. The paper specifically describes this tiered approach of focusing on using the disease management guidelines, of teaching self-management education, and then ultimately including home visits as part of that comprehensive asthma care service. And at the same time, this Governor Association report also talks about the importance of stratification, the importance of analyzing data, the importance of understanding some concept called the return on investment for your program that we'll talk more about. So how do we evaluate our programs? How do we understand the quality of our effort in trying to help patients? There are some key components that over the years we've learned and others have learned are particularly valuable. So what we want to know is ultimately the impact of the program. What kind of outcome is there for the patients? Are they feeling better? Are they managing their disease better? Through that process, if they are managing their disease better, we should see a reduction in their healthcare costs. We should see a reduction in their utilization of urgent care services. So we should be able to track that and see what that kind of impact is. And there's certainly a method and a structure to that. It's identifying what kind of data we want and then ultimately calculating what we call the return on investment, which is basically the input or investment of service and care delivery, and then ultimately what kind of savings do we see in return and what kind of health improvement we do. And for those of you that have a program that is trying to figure this out, one strategy is ultimately to have some kind of pilot project, select a group of patients or a population that you might want to work with, a smaller set, and use that to test a certain model to see what kind of return on your investment you might have. To be clear about this, then, a return on investment is specifically a process for using data about the healthcare service costs related to implementing a program, and then simply comparing that to the savings from the program as you deliver it for the patients. So having a mechanism or a process for collecting that data and managing that information so that you can look at it periodically and understand what the data is telling you about the success of your program. And we'll talk more about that. There are key components to that. So it helps you identify the population that you're trying to serve. It helps you identify what for your program maybe, or for programs in general, what are the cost drivers for your program, what are the challenges, where are your expenses. It helps you understand opportunities for improving quality while trying to reduce your overall expenses for managing the program to make it more efficient and cost effective. It's also useful in understanding how your program is designed or how to design a program. I think if you go through a process of knowing what your ROI is, it's a way of organizing your program and knowing what resources you need and then how to evaluate those resources and whether you are using them effectively and then the costs associated with those resources. And then ultimately, and probably most importantly, it's a great tool for knowing what you believe your program is doing and ultimately computing and understanding if it is in fact doing what you hoped. And I think that's often the thing that people don't realize. You can be an idealist like me and dream up what you think would be an ideal program, but there are so many realities and challenges that make it difficult, and it's important to try to develop the program and then along the way use effective tools for evaluating what's working and what's not working. So you're always adjusting the quality of the services or connecting with new partners to offer new services. So it's an ongoing tool that you use all the time. So these are some of the components of the data you might select. And if you're going to do a pilot program, it would be a good idea to select a population or a size of a target population, or if you have a whole program you're working with, knowing what the size of that population is. I'm a big advocate for the idea of risk stratification, stratifying patients based on that utilization. We'll talk a little more about that. Having some sense of the enrollment rate, how often and frequent you are enrolling new cases and cases from different geographic regions, for example. What is the actual duration of the program? Knowing what your baseline costs are, and then any additional services. Those are all components you're going to want to have in evaluating your return on investment. And then different kinds of data, fundamentally health utilization, the ones we know of related to hospital costs and ED costs and medication and procedures, but also just the labor of staff, the effort of staff in staying in touch with individual patients and their families. Routine communication, what kind of effort occurs at the home, what kind of effort occurs at the clinic or at a school setting. All of your education materials. And then if you do home interventions, which I recommend, what are the costs of those interventions? What are the costs of the services of hiring programs or housing programs or partnering with them to provide home intervention services? Fortunately, there are some excellent tools, excellent research publications out there to support your work. This Center for Healthcare Strategies tool for forecasting return on investment is an excellent tool, even if you use it just to frame how you might organize your program and how you might evaluate your program. Its original intent was for understanding the value of patient-centered health homes or medical homes as that model of care is adopted across the country. But it actually is an excellent tool for understanding a specific component of a program, and they use, it turns out, for some of their examples, asthma programs. So it becomes a good way and a good example for understanding how to evaluate the components of an asthma program. So just touching on some of the components, you put in your target population here. You develop some kind of method or mechanism for deciding what your a risk stratification might be, who might be participating in the particular program that you want to analyze, whether it's the high risk or all of them, high, medium, and low risk, whatever that is, what that enrollment rate is. Then putting in some specific costs, and these are just projections based on what you know, either from your own information or from what you found that's been published. Using that information based on a certain number of patients, you can come up with a model for how much care cost you think it might be per individual patient. And then you can set up what your goals are for decreasing utilization, for reducing some of those healthcare costs, and ultimately allow you to build a summary of what kind of impact you would project for what your program might do. So it's a great tool for trying to understand, and not maybe your whole program, but what kind of data you might want to collect and track, and how are you going to collect that information? Is it coming from electronic health record? Is it coming from partnerships with clinics? Is it data that you track in your own data system, or are you doing it on a hard copy form? Do you have mobile tools that you can use to collect data in the field and have that populate into a database? It helps you to guide and understand what kind of data you need and what kind of questions you want to ask as you develop the program. There's also excellent reviews of what programs have done and what kind of ROI they have reported. This is an excellent review by Joy Sue and her colleagues about the economic evidence for asthma self-management education programs and home-based interventions. It came out in 2016, and they looked at 42 individual programs that they were able to find across the country, 9 of them specifically asthma self-management education programs, 17 of them being home-based, so they had both the asthma self-management education and a home-based component. And then they looked more deeply at specifically at what each of these programs did as a service, and then what kind of, if they did any kind of study, was it a randomized controlled trial, was it a pre-post analysis, and then what kind of outcomes did they see, and did they report any kind of return on investment data. And in this case, these programs all reported some kind of positive ROI, and interestingly, many programs observed a positive return on investment when they focused on the higher health utilizers. And that makes perfect sense. Those are the ones that are costing our healthcare system the most. Those are the ones who are struggling to manage their disease and where we might want to target some of our effort and services. At the same time, they found one of the challenges with trying to do a uniform analysis of programs across the country is there was a lot of variety in the kinds of services that programs offered, and that made it difficult to have a consistent measure for what return on investment might be. Personally, I think that's okay, because geographically around the country, you're going to find that it takes different partnerships, different collaborations, and different strategies to try to help families improve their asthma disease management. So just a brief look at some of the tables, and that's the nice thing about this study is they do a really nice review of these and specifically tell you what the interventions were, what healthcare utilization was evaluated, and then what the economic outcome was, specifically what the return on investment was. Was it, as in this case, $6.35 per dollar of investment, or was it less? It's a really nice summary of what these programs did and gives you an opportunity to really look at different approaches that programs have taken across the country. And here's another look at some of the additional components that are included in there where they specifically describe many of the services that different programs offered. So it's really nice detail. And here's just some more of those. So our program was identified in here. So we had a program that ran from 2001 to 2010. That's analyzed in here, and you can see here the reduction in ED and hospitalization that was looked at, and then the net savings based on a 43 cents per member per month cost and a gross savings of $2 per member per month for this program. And our successes, we've been at this a while and have seen things go up and down as we've tried to implement various strategies in our program. And in 2016, in trying to better identify patients and do a better job of stratifying risk, we looked specifically at the data from our hospital system and used that data to predict healthcare use of children with asthma. So we took a population of 28,000 outpatient visits representing 10,800 patients over the years 2009 to 2013, and we looked at their data from a particular point in time for an outpatient visit, and we looked at their data in the past 12 months and wanted to understand how predictive that was of an acute care visit in the next 12 months. And what we found was the more acute care visits that a patient had in the past, the greater the likelihood of a future acute care visit in the next 12 months. So here, looking at 2 historic acute care visits, we find right about a 45 to 50% likelihood of a future acute care visit. With 3, we saw about a 60% likelihood, 4, about a 75 to 80% likelihood, and 5 acute care visits, you saw up to a 90% likelihood of a future acute care visit. So we use this analysis of the data to develop a high-risk asthma protocol within our electronic healthcare system. So when a patient is touched by one of our clinics or hospitals or inpatient or ED, we can look at and do this quick analysis to identify who the high-risk patients are. They're automatically enrolled by the system in the high-risk asthma protocol. They're automatically referred for social work. They're automatically referred for an environmental health referral, and then they're given the opportunity to connect with different outpatient elements, but in particular, the opportunity for an environmental assessment. They don't automatically get a home visit, but we certainly talk with the family and try to determine what their needs might be. Then our Asthma-Friendly Home Program does a further risk stratification using that healthcare utilization as a representative of past utilization in combination with their current asthma status using the asthma control test, and then a simple survey we've developed that we call Tell Us About Your Home, which is a quick survey of current environmental exposures that the family is experiencing and trying to manage. We use all of this to determine their total asthma risk, and then based on that, they're stratified into different levels of service. So those who are lower risk are given the opportunity for a basic home assessment. Those that are higher risk, typically more complicated health problems, much higher utilizers, but also often a more complicated environment that they're trying to manage to try to reduce exposure to different types of environmental triggers. We've been in many, many homes over the last 20 years. We provide a focus on healthy home education. We do a visual assessment, and then for those advanced or high-risk patients, we might do a little bit deeper dive into the home and understanding and diagnosing potential exposure risks to help us target our interventions to address specific environmental risks and hazards that we might identify in the home. Like many programs, we have a multi-visit management model, so multiple touches and visits with the family. That's been shown by many programs to be very important to maintain continuity of service, maintain education. We use this opportunity for the phone surveys to use the ACT score once again, check in with the family and see how things are going in the management of their disease. And we stratify the number of visits provided as well based on whether they're high risk or low or medium risk. So through our process, we do a home assessment. We identify and make recommendations for healthy home actions that both the family can do. We provide healthy home supplies. We provide specific interventions when we have funding to support that, or we refer families to housing partners who can make fixes to a home, try to reduce the potential for exposure to specific environmental triggers, and ultimately try to improve the indoor environment of their home so that it's easier to manage their child's asthma. There are lots of great resources. I highly recommend, if you are interested in knowing what some programs have been doing, the National Center for Healthy Housing has these excellent case studies and resources here at this website that will be made available to you. And then here's just one of the examples of a program that they describe in one of those case studies. So looking at their total cost, it was roughly $1.3 million in total cost, and then a net benefit of $2.5 million. So clearly a significant improvement in savings and better care for those patients. And you can see the reduction in utilization as a result of participation in the program. But I want to point out that even though your program might be looking at and focusing on a return on investment and making sure your program is cost effective and efficient, it's not that easy. So many patients are dealing with complex challenges, have a host of comorbidities. It makes it very difficult for them to manage the disease. Many of them are dealing with a host of social determinants, complexities in their community that lead to health disparities. Overcoming those challenges and barriers is always difficult. And ultimately, a part of any asthma management program is a goal of improving the overall community health. So there's an underlying mission that's more important in my mind than the return on investment, but having the ability to analyze the effectiveness of your program provides you a constant opportunity for evaluating how you're doing and just trying to do better. And ultimately, trying to do better in how you help Jeremy. And I'll stop there. Thank you very much for listening.
Hi, this is Dr. Ben Francisco, and I also appreciate very much the opportunity to speak to you today. I want to address data-driven approaches for improving asthma care and control while lowering costs. And so the focus is to use data to support and demonstrate real results in children with uncontrolled asthma, and to talk a little bit about the importance and difference data makes in sustaining our programs for long-term success. So This is really a story. I'm not going to speak to every slide in detail, but I want to weave a story in the next 20 minutes that touches on how we establish goals and focus on what we're going to change, which authoritative sources guide us, what are our evidence-based drivers, and is our intervention based on a framework or a theory or some cohesive model that others can use? Which outcomes do we believe show success, and which data are required to show progress towards goals and then actual outcome differences? And I think the most important is, can this be scaled? Can this really affect large numbers of people? And is there a business model to sustain it? We need strategic partners, and today we need to show return on investment. So I'm going to talk a little bit about two different Missouri asthma improvement initiatives that illustrate these ideas. And I do have an emphasis on administrative claims data. I hope I can share what we know and what we're learning on that topic. I also want to touch on, as Kevin has, an integrated model for assessing asthma status, not just based on clinical information, but based on self-report, community assessment, clinical, but also claims data. And finally, I think this moves us towards a population-based approach that asks for us to match workforce development and service delivery to meet local asthma burden. And I do believe in the triple aim: better care, better health, and lower costs, and we see that that is possible with childhood asthma. The first piece of work here in Missouri that I want to share with you was funded by the CDC, and it's called Teaming Up for Asthma Control. We had great evidence that school nurses needed additional support, that they did not have the things they needed to address the needs of students. They lacked training, they lacked equipment. They didn't even have quick relief medications on campus for the students who were having difficulty breathing. And they had no educational materials and lacked uniform policies. We fortunately have great evidence. The EPR3 guidelines clearly are authoritative, but we also have school-specific initiatives. The National Asthma Control Initiative from Heart, Lung, and Blood, as well as the American School Health Association, had delineated the possible roles of school nurses in improving asthma control. So our project really focused on promoting school nurse competency, and that would allow the school nurse to collect clinically relevant data around impairment, the ways in which asthma limited children, but to also monitor and report asthma control status so plans could be adjusted, and particularly to focus on improving student self-care and to promote family awareness of the importance of healthy homes and environmental factors. I think our evidence-based drivers came straight really from GIP, the Guidelines Implementation Plan, which really said these are the big drivers. If we're successful implementing these in clinical care, in school, in home, in community settings, then we're very likely to see a big impact. And that potential impact had been described in 2010 in Chest's Physician. The cost savings that were reported for families as well as for insurers were substantial as asthma control moved into well-controlled status. Our other goal addresses data gaps. In Missouri, children with Medicaid have on average about one outpatient visit for the management of asthma per year, and many visits that are acute care visits because they're sick. So we felt that the school visit would be an opportunity to obtain assessment and monitoring data at an affordable cost that would support clinical decision making. This fits the framework of collective impact, which basically says we can't do all the work in the clinic or the hospital, but many other settings have benefits. So we took our focus on school to do as much as we could in the school setting to complement other settings where children's needs were being addressed. We looked at the expert guidelines and we translated those for the school setting and found 4 key messages. You must measure airflow, FEV1 being the preferred measure in home and community settings. Inhaler identification and training for optimal inhalation technique was critical because inhaled corticosteroids absolutely improve control and reduce acute care and morbidity, but that triggers also have to be avoided. Families need to know what those are, as well as the other disease conditions like gastroesophageal reflux that impact children. So we were able to train school nurses first to identify children who had persistent asthma so that they could recruit those children to participate in 3 school nurse encounters. There were 176 children in this study, and each child had measurement of the FEV1 at each of the 3 visits. We used Children's Health Survey for Asthma Child version, which, unlike the ACT, does not require parental input and is valid for children 6 and above. We used the same survey to assess psychosocial well-being related to asthma. We determined the adequacy of ICS inhaler technique, measuring inspiratory flow rate and time using a device called the InCheck dial. And we used inhaler charts to help children identify what the red inhaler or the orange inhaler actually is and how they should be using it. And we used childhood asthma risk assessment tool to assess environmental tobacco smoke exposure, as well as other environmental factors in the home that children can recognize. And importantly, we did deliver asthma self-management education using an evidence-based program that we developed here called Impact Asthma Kids. That program is driven by self-regulation theory, and I know some people don't like to talk about theory, but self-regulation is terribly important for the individual, but it's also important for the clinician, and it's also important for the health system and insurer. And in this model, we're vigilant. We're looking for data or evidence that there's a problem, and then we have ways of acting to address the problem. And then when we're in a steady state, we go back to a state of vigilance. And we've actually applied this to children, to clinicians, and to health systems and insurers effectively. We did publish a randomized controlled trial of the asthma self-management program, 228 children. We are listed in the EPR3 guidelines as one of 3 computer-based programs that showed significant positive health outcomes. We relied heavily on the NIH investment in developing CARET, Childhood Asthma Risk Assessment Tool, across the 25-year period of time, where we were really trying to understand why are so many people struggling with asthma control. What are the barriers in the home? And so that tool is very important to us and was integrated into this school-based program. There were another number of very positive outcomes that we have published, and that included about a 12% increase in FEV1, a significant decline in impairment, a marked increase in ICS consumption by the child, and a very important improvement in the adequacy of the inhalation effort measured objectively. We were thrilled to see that children psychosocial functioning improved, that there was significant reduction in frustration, isolation, sadness, anger, embarrassment, and students self-reported that their tobacco smoke exposure declined significantly after education of families and as well as teaching children simple avoidance methods. The program was well received by parents and students, and we were fortunate to have approval from Missouri Medicaid to analyze cost using claims data. This all occurred in a period of time, 2009 to 2014, where there were significant annual increases in the cost of asthma in our state. We invested about $150 per student in the delivery of this program, and we saw about more than a $1,300 decrease in the cost per child. So the ROI was about 7 to 1 in the first year, and we would certainly expect, but have not analyzed, savings that would occur in the second and third year. So I think there's a variety of data that were involved here, but these helped us to successfully show a reduction in the rate of uncontrolled asthma and about a 30% reduction in Medicaid costs. If you Google teaming up for asthma control, you can readily find that article, and I hope you will, and send us your comments after reviewing it. So what about an integrated model for assessing asthma status of individuals, meaning that data from different sources and different types are brought together? This suggests that it's really the person that should be the center, like Jeremy, that Kevin mentioned, the person and the family at the center, and then the medical home and the community partners, the insurer, the government, all others really are around them helping. We particularly believe that community interventions like home environmental assessments, home asthma education, when they're coupled with standardized assessments and when those data can be then joined to claims data, are very powerful ways and cost-effective ways to improve outcomes. So we think of 4 critical data sources that really need to be integrated. That's what patients say and their families about their asthma. That's what clinicians are doing and trying, believing about the asthma, but certainly what insurers pay for. Administrative claims tell us a lot. And then we want our community partners to be linked in this analysis: pharmacists, school nurses, educators, in-home services like environmental and asthma education. This is consistent with expert guidelines for how to deliver the highest standard of asthma care. In this case, this is a diagram talking about when you should step up therapy. You should first check adherence, and claims is the best way to do that. You should check inhaler technique, not just once, but in multiple settings to know that the person has the skills needed. And you need to consider environmental control, because environmental drivers are often behind a worsening pattern of asthma. In Missouri, for more than a decade, we've had access to Medicaid claims data through a program called Cyber Access. That gives you a look at what's being dispensed from all the pharmacies the patient might be using and from all of the providers who might be prescribing medication. And it gives us quite a bit of power in looking at the individual patient by sorting the types of medications and so forth. It also allows ready identification of medication-related problems, or NRPs, that might be addressed by pharmacists or asthma educators and others in the community. Things like low rate of ICS refills, excess dispensing of albuterol, no evidence of having had spirometry in 3 years or more, ER visits, and so forth. Finally, I want to kind of put this together with a population-based approach that would really, I think, empower us to get better outcomes and lower cost. This is consistent with the National Academy for State Health Policy, who suggests that Medicaid claims data and encounter data are key to moving forward with value-based health care. So we have a second project here in the state of Missouri. We have about 55,000 children with asthma that have Medicaid. 20% of them have uncontrolled asthma at any point in time. And what we've discovered is healthcare providers as a group have a low adoption rate of best practices, which means if you take the expert guidelines and you say, are you doing this every day in your clinical care of children with asthma, we find that on average, out of about 32 best practices, only about 30% are commonly used in our health homes. And that's prior to engagement around asthma improvement and training. So we've been fortunate to have a program here in the state called ECHO, Extension for Community Healthcare Outcomes. And we've been fortunate to have new policies over the last decade that clearly support appropriate asthma care, including a state plan amendment to reimburse providers for delivering in-home asthma education and environmental assessment for trigger reduction. We have specific CPT codes now that do appear in claims data, so it's possible to see which patients are receiving those. So our project currently is called Promoting Asthma Best Practices, or the subtitle of that is the Asthma Care Accelerator, meaning that we're putting together dynamic features that allow us to make progress together faster. This falls under the rubric of the Learning Health Systems Framework. It relies on the ECHO platform, which is video teleconferencing. We've already connected over 1,200 healthcare providers and over 100 clinical sites and agencies in the 4 years that we've been working on this. We provide continuing education credit, CME, advanced pharmacology credit, and maintenance of certification, Part 2 and 4, which I'll explain briefly. The local clinic does their own run charts over a 6-month period during this engagement. to document implementation of best practices. They choose what they want to add to their practice, and they document the percent of patients with asthma care, receiving asthma care, who do have those services, such as measurement of FEV1 or coaching for improved inhalation technique. We're able to provide them claims data for the year before and the year after participation. This is supported by the evidence. There's an article published by Molden Group called Implementing Asthma Guidelines Using Practice Facilitation and Local Learning Collaboratives, a randomized controlled trial. And they're basically 4 movers, 4 drivers for improving care. We've been able to integrate all 4 of those in the Asthma Care Accelerator program. This is in many ways not a new concept. In 2004, an article entitled Asthma Days was published that provides us a model for how to stand alongside practicing healthcare providers and help them be more effective and have better outcomes. So this is our form for assessing asthma best practices. Again, there's 32 items, and most people are starting at about 30% of those best practices being routine. We're able to look at claims data to validate or question some of these findings. In the survey of our participants, about 70% say that they use specific J codes to indicate the level of asthma, but the claims analysis says only about 30% of children consistently have a J code that reflects the specific level of asthma. And of course, the significance is if you don't call it right, you can't treat it right. So again, we use learning health systems, we use ECHO. We have an amazing team of local and national folks that are on those video calls and that actually travel out to clinic sites and help us. We have wide distribution across the state of clinical practices, and we're really trying to drill down and sort of use mapping to get specific about where the kids are. The red dots are 13,000 children. The blue dots are our primary care health homes, and the color gradation tells you how far it is for that patient to reach a place where we're working to improve asthma care. We're also looking at burden by school district. These are red circles showing large groups of children with uncontrolled asthma, over 400 on those largest dots per district. And we are working at the level of creating community hubs where there's engaged clinical practices, engaged schools, and home visitor workforce to do environmental assessment. We're really focused on what is high impact but low cost, and there are a number of things that are clear standouts that don't take a lot of money but seem to have a very large impact. We are spending a lot of time trying to translate these data in a way that's easy to act on or actionable. Red means this patient's got a lot of problems in this arena. Yellow means it's a problem, and green means we're pretty much where we need to be. Environmental interventions are integrated into this claims analysis and report. This is an individual provider's report who has 172 patients with asthma. Almost 30% are uncontrolled. 69% of their care is outpatient or preventive, but 31% of the care is still happening in the emergency room. We give them a summary of their ICS use. We look at the business model, how many missed outpatient appointments or opportunities you would have expected for that population. And then the last item on this list, what services can I offer? We do have an algorithm for predicting which patients need a home environmental assessment based on ICS use and morbidity. So summing it up, we really focused on better care, better outcomes, but also greater professional satisfaction with increased clinical revenue. One inpatient day equals about 20 outpatient days financially. So we want to increase the outpatient and preventive care and lower the overall insurer costs and total health care costs. We very much appreciate our sponsors who have helped us reach this point. Thank you very much.
Wow, thank you, Kevin and Ben. Kevin, I think you said you didn't consider yourself an expert. I think you're being very modest. Thank you for sharing your expertise and the fabulous information and practical information on collecting and analyzing data. Before we close, I'd like to do one final polling question for folks on the phone. If you would mind, based on what you heard today, what will you do next to improve your asthma data collection or use data to improve asthma control? Please select all that apply, so you can select more than one at this point. Great. So fabulous. Many of you will work to collect better data and analyze those data. You'll be working with community partners. We have lots of information on Asthma Community Network, as well as ways to connect with community partners. And then hopefully you'll all visit Asthma Community Network, the resources there. Like I said, there's information on business case development, on sustainable financing. We have the sustainable financing microsite. So many, many resources to help programs that are at any level of development or in the process of seeking reimbursement and sustainability. So at this point, I'd like to remind you that we will be closing the webinar, and we will be going to Asthma Community Network for the next 30 minutes with our speakers. So you'll have an opportunity to answer questions and interact with them through the discussion forum. Here's a reminder on how to access the discussion forum on Asthma Community Network. And as I said, look for the webinar to be archived there for your future reference, as well as the question and answers. So we're right at the top of the hour. I'd like to thank Kevin and Ben again. And at this point, that concludes today's webinar. Thank you.